Hi, and welcome to Qualidyme's learning module on initiating buprenorphine in the emergency department. Qualidyme, in collaboration with Blue Water Emergency Partners, Harem Consulting, Elaine O'Connor, DMP, and Leah Bauer, MD, is working under a contract with the State of Maine Office of Maine Care to provide education and technical assistance to interested hospital emergency departments, focusing on how to initiate buprenorphine in the ED setting. The access to buprenorphine inductions in the ED is important in Maine given the complexities of the opioid crisis and the inherent challenges of Maine's rural population. As part of the technical assistance being offered to EDs throughout Maine, the project team recorded this module which focuses on the case for why offering MAT in the ED, as well as the data behind it, addiction as a chronic disease, and the basics of buprenorphine. You will be hearing from 3 presenters throughout the course of this module, and each of which actively works in a health system that offers inductions in the ED. The first speaker you will hear from is Ranjiv Advani. Dr. Advani graduated from the University of Michigan Medical School in 2000 and completed residency training in emergency medicine at Maine Medical Center in 2003. Since 2009, he has worked clinically at Midcoast Hospital and is a founding partner of Blue Water Emergency Partners, a private democratic emergency medicine partnership based in Maine. Dr. Advani is the medical director of the Midcoast Hospital Emergency Department and leads a team of 15 physicians, 11 APPs, and 2 APP fellows. He is also currently the president of the medical staff at Midcoast. Special areas of interest include medical error and cognitive bias, tribalism in medicine, provider resilience, and substance use disorder. You will also hear from Dr. Leah Bauer today. She is a psychiatrist and medical director of Addiction Resource Center at the Midcoast Hospital in Brunswick. She is board certified in addiction medicine as well as adult psychiatry. She graduated from the University of Cincinnati College of Medicine and went on to residency at the Massachusetts General Hospital and McLean Hospital Adult Psychiatry Program, graduating in 2013. She has a strong interest in medications for addiction treatment and developing innovative models of care. She has presented at local and national meetings on these issues. And our final speaker will be Elaine O'Connor. Dr. Elaine O'Connor is a faculty member of Maine Dartmouth Family Medicine Residency and is on the medical staff at Maine General Medical Center. Her clinical work focuses on addiction medicine and the management of opioid use disorders using buprenorphine. She developed an integrated medical and behavioral health treatment program that has served hundreds of opioid-dependent pregnant women over the past 10 years. She also works to expand access to medication-assisted treatment in the primary care setting by mentoring other clinicians and practices. She has academic appointments at Dartmouth Medical School and Vanderbilt University and is a peer reviewer for a variety of journals. And now I will turn it over to Dr. Ranjiv Advani, who will begin the first section of our module.
Thank you very much. My name is Ranjiv Advani. I am an emergency physician and the medical director at Midcoast Hospital and a member of Blue Water Emergency Partners. I'm going to start the webinar off today talking about why do MAT in the emergency department at all? Why should we be doing this? And why, in particular, the ER is well positioned to intervene on this problem. We're going to talk a little bit about why we are here and a little bit about the opioid epidemic, as well as the Yale study that came out that really changed the landscape of defining how the ED could get intervened, and some of the lessons that we've learned after doing this for a couple of years. If you are in a Maine emergency department, you are in good company. Many of our colleagues around the state have either started a program on their own or are in consideration of starting a program. This is a list of the current Maine hospitals and where everyone was as early as the spring of this past year in 2019. And many of the places have reached out to us to collaborate with and start their programs. And we are always here to help out, answer questions, and help troubleshoot. Really, when you think about how emergency departments can get involved in the opioid epidemic, we can really approach harm reduction in 4 different ways. We can look at prescribing patterns and hope to lower prescribing as well as tracking prescriptions. Many of us are also talking about alternatives to opiates for pain management in the emergency department or for going home, and using guidelines as well as provider and nursing education. Thirdly, we're talking about doing Narcan prescribing and dispensing for many of our emergency departments, as well as education on how to use this. And lastly, really getting involved in true treatment for addiction in medication-assisted therapy and referrals. And so this last fourth pillar is what we're going to be talking about. As many of you know who work in emergency departments, the ER is really the front door for many of the patients that are suffering from some sort of substance use disorder. And for many of us, you really can't go even one shift without seeing the effects of substances on our patients. And whether or not you're seeing someone after an overdose, someone who is suffering from medical complications of their use, such as abscesses, hepatitis, variceal bleeding. We see patients coming in with diversion and deception. We also see the effects of substance use disorders on families and pregnancies. And lastly, we see patients that come in simply just asking for help with their problem. We are really positioned at the front door of many of our healthcare institutions, and as we're mandated to take care of anyone, regardless of their condition or ability to pay, we now function in many cases as the social safety net of our communities, and really sometimes are the only access point for many patients who a lot of times have really become disenfranchised to healthcare. As many of you know, overdose is now the #1 cause of death for Americans under age 50, and is really one of the big reasons why actual life expectancy for Americans is falling for the last couple of years. In between 1999 and 2016, there were more than 500,000 overdose deaths in this country. The epidemiology is something that we've heard a lot about, and I don't think that we need to go through this too in depth, but just most notably, and many of you probably know this, overdose deaths now greatly outweigh deaths from motor vehicle crashes. We've done a lot of education and safety interventions in the motor vehicle world, and are now just catching up in opioids. Maine, in fact, enjoys somewhat of a dubious distinction of being in the top 10 of opioid-involved overdose deaths. In 2017, we had a rate of about 30 deaths per 100,000 people, and the national average was around 14 deaths per 100,000 people. We don't really write any more prescriptions than anywhere else, but we are now currently really suffering from this epidemic among the top tier in this country. One thing to remember is that the overdose deaths that we're seeing is really the tip of the iceberg. And so for every death, there were probably 18 people that were using heroin, even more using prescription opioids, and a substance use disorder, and even more who are just misusing opioid prescriptions in the last year. So why do this in the emergency department? Well, again, we're positioned to see a lot of these patients, and like Willie Sutton said about robbing banks, that's where the money is, and in the emergency department, that's where the patients are. We've seen a 30% increase in visits in overdoses just in the last year, in the year between 2016 and 2017. And really what we're trying to do is trying to get people to start thinking about this problem in a couple different ways. From just a simple harm reduction model, there are things that we can do, such as prescribing Narcan, lowering our prescription rates. But really, if we want to truly intervene on this, we want to start embracing opioid use disorders as a disease, and that it's one of a chronic relapsing disease, much like many of the things that we see. And you're going to see Leah Bauer talk a little bit about this in the next section, but really wanting people to embrace this as not a moral failing or a decision, and treat this much like we treat other chronic diseases like diabetes and asthma, hypertension, that we stabilize in the emergency department and hand off for outpatient care in hopefully a seamless way. And what we need to do then is to create systems to do this. The old way that we used to do this, in particular for someone, say, simply seeking help with their use and wanting detox or treatment, is really we would kind of give them a phone number and a handshake and send them on their way. And I think that when we've talked about this more, I think this led to a lot of frustration among our providers. If you really feel like you're not able to help with a problem, it leads to feeling of frustration, feeling impotent that you can't really help, and I think leads to a lot of the negative feelings that we as a healthcare institution have developed towards these patients. Not that this is not a commonly difficult patient population to deal with at times, but the argument that I had is that some of the bias and some of the stigma that is attached to these patients comes from our own frustration. And so how can we get involved in a meaningful way? Well, the landmark paper that came out that was published in JAMA in 2015 came from Yale by an author named Gail D'Onofrio. And this paper really showed not only that this is possible to get involved in the emergency department, but that it also was effective. And so I'll just take you through this paper really briefly. They looked at 3 groups of patients with opioid use disorder that they randomized. The first was the traditional referral, sort of the old way of the handshake and a phone number and sort of get out of my ER model. The second group was a brief intervention like an Iceberg model and the same type of referral with a phone number. And the third group was a group of patients that they initiated buprenorphine on while they were still in the emergency department and got them off to treatment. And the primary outcome that they looked at was engagement in treatment at 30 days. So the results that they had were actually quite striking. And so in the buprenorphine group, you can see almost 80% of the patients were still engaged with therapy at 30 days compared to 37% in the referral group and 45% in the brief intervention group. So really almost twice as many patients still involved in therapy. They did look at some secondary outcomes and looked at self-reported illicit opioid use in the past 7 days. And while the buprenorphine group was not 0, it was still half as many or less than in the referral and brief intervention group. And so we can't really say that this is a failure because we haven't reached complete abstinence, but we have to acknowledge that this is, again, a chronic relapsing disease. You know, the idea is that the patients leaving from the emergency department with buprenorphine administered, their withdrawal symptoms are mitigated. And if you get them into treatment quickly, they oftentimes just feel better. And we know that living in withdrawal, that people describe as feeling the worst you could ever feel, is an eternity if you have to go for 1 day, 2 days, 2 weeks, 4 weeks until you can get a referral and an appointment. So we've been doing this now at Midcoast for the last couple of years. Many of you have also had experiences with it, and I thought we would just share some of the reflections that we've learned. Really what you need in order to get this done is 2 things. Really pretty simple. You need an emergency department that's engaged, and you also need a treatment center that's going to get you rapid access and guaranteed quick access. We had it relatively easy at Midcoast when we started this, as we really just brought together 2 groups, the addiction community and the emergency department, that were previously somewhat siloed, and created standard expectations and communication pathways. As many of you know, however, this is one of many, many, many projects and initiatives that the emergency department has asked to become involved with. And this is really fitting into sort of the new model of medicine, and the new model in particular of emergency medicine becoming more integrated into the system and building the pit crew that is needed to take care of patients. But the other thing that we need to do while we ask you guys to do more is to make it easy for you to do the right thing and create the standard pathways so that you're not reinventing this and inventing it on the fly as you're trying to take care of patients. So we need standard expectations, standard pathways so that the wheels are greased, so to speak. The basis for these programs really kind of is based on seizing the moment of the opportunity to intervene. Oftentimes, people are motivated by many different reasons to seek treatment, and that motivation may sometimes be fleeting. That motivation may not present itself again if not taken at the time, and sometimes when we turn people away with just a handshake and a phone number, we're not really seizing on that moment. And even worse, it can send an unwelcome message, and that patient may be lost forever to treatment. This is a patient population that's extremely sensitive to judgment or feeling judged, and we have to acknowledge that not only our verbal and our nonverbal communication can send really powerful messages. The motivation can come from many places, and we like to be able to tell some stories as we go on. And one of our first patients we started this program on was a 23-year-old woman who previously had been a very frequent visitor to our emergency department, but was now pregnant in her first trimester. And she had a child at home and was using heroin every day. And we were able to get her started on treatment in the ER, get her to the Addiction Resource Center. And as far as I know, she's still in therapy, in treatment, had her baby, successfully parenting both kids and holding down a job. The ER really is the only place in medicine that's open 24/7 and has open doors, and it really expands the access and entry points for people into these types of programs. Even if people don't take us up on our offer and get involved in the program right away, it gives us an opportunity to tell a story and plant a seed for patients so that they know that when they are then motivated to seek recovery, that we're here to help. We had an overdose patient that came in after an overdose, being resuscitated by Narcan. Literally his life saved by the EMS folks in the field. And as many of you know, those people really just don't want to be in the emergency department any longer than they need to be. And we're commonly finding that overdose patients do not really want therapy. But he was offered the program. He initially declined it, but because that seed was planted with him, he actually returned a week later and got directed into the program and is in recovery. ED providers, like many of us, many people really like to have problems that we can solve. Previously, we had very few tools to deal with this problem. And again, as when you have problems that you can't solve, that leads to a lot of frustration. And so now that we've given our providers a tool, we can actually ask our ED providers to get involved with this problem. That allows us to somewhat shift the paradigm, and really what we like to say is roll out the welcome mat for patients with opioid use disorder to the healthcare community, and a welcome mat that really unfortunately wasn't there. It sounds somewhat counterintuitive to many providers who don't have experience with this program, but truly once we started doing this, it led to not only a welcoming of these patients, but a transformation in many of our practices. These were visits that previously, many providers shied away from, tried to avoid at all costs. And now we're finding our providers are driving themselves towards these visits and towards these encounters because they know that they have the tools to take care of them. We had an abscess patient who would come in with an abscess that he got from injecting. He was offered the program on the first visit and declined. He really wasn't ready. And I saw him on the subsequent visit to look at the wound and change his packing, and again offered him the program, and he still declined. He wasn't really motivated at the time, but he said, I got to tell you, you guys are really cool. You talk to me like I'm a real person. And the argument I have is that, we're more able now to sit down and talk to these people in a way that we wouldn't previously, again, because we have the tools. He told a story of being at the dentist, and when they found out that he had an opioid use disorder, he reported they really just stopped talking to him. Lastly, I want people to start thinking of opioid use disorders and overdose in particular as an emergency medical condition. and one that really truly fits well into the paradigm of emergency medicine. Many of the things that we train for and get involved in, such as stroke, STEMI, sepsis, trauma, are what we call low volume but high impact things. These are things that, if not intervened on early, have a high likelihood of mortality. And in fact, when you see someone with a non-fatal overdose, those patients have about an 8 or 9% mortality in 1 year. That's not any lower. In fact, it's higher for things like non-STEMI, and even STEMI mortality at 1 year is about 7%. And so really looking at this as an emergency medical condition that we can intervene on, stabilize, and get to the correct treatment. As just a quick feedback and a story to tell, this was a follow-up visit that one of our colleagues got from a primary care physician who said, "I just wanted to give you a huge thank you and kudos for your work on the ER induction of Suboxone with follow-up. I took a call a few weekends ago. A mother was picking her daughter up from jail. She was in withdrawal and wanted to be cleaned, but did not feel she could make it until openings in the traditional rehab setting. This had led to a pattern of using more and more legal issues. Being able to coordinate with the patient's mom and the ER team to get her immediate treatment was really powerful. Mom said, 'You are a lifesaver,' and I feel like it's true." And so I think really this is a really, truly high impact situation. And again, I think a win-win. It's a win for our patients and a win for you as a provider as well. It's obviously one of the many, many, many programs that we're asking you to get involved with and understanding the systems. And the ER is now becoming more and more integrated into the healthcare system as a whole, and this is a good thing. And so I can't argue that this is going to be any quicker or necessarily easier than the quote-unquote old way of the phone number, but I think clearly will have much bigger impact, not only on your patients, but also on you and your providers. And so now I'll turn it over to Dr. Leah Bauer, who's going to talk a little bit about addiction science and evidence-based treatment for addiction. Thanks a lot.